allergic to nickel, so anything with the cobalt chromium is not a go for me. So I had to look for something else, and like my doctors told me that I was getting a hip replacement, and I just was horrified. So I was blessed to find Patricia's website, and I've been doing, it's been my full-time job because I had to leave my job because I couldn't do it anymore. And researching this has been my full-time job for about a month.
Well,
yeah, I mean, he has, I looked at he has one report on 8-year data there. He's had decent results there, which I guess should be public. He had a survivorship. He had about 190 hips with five or six revisions at the 8-year follow-up, which is not bad. But again, that includes the early learning curve.
Yeah.
So you would have a higher revision rate at the beginning. I'm always a little concerned by the first people in on one prosthesis, which is what we had when we first started doing resurfacing in 2000. We had a higher failure rate until we got more experience. So clearly he's done this a longer period of time. If you're allergic to, it still uses, you're allergic to what were you saying?
Nickel. And nickel, apparently, I was watching one of Dr. McMinn's things, and he said that nickel is in the cobalt chromium devices.
The surfacing that he's using, Pritchett, has cobalt chromium also, so it's not devoid of nickel.
No, but the one he's using for me is going to be the ceramicized titanium.
All right, well, you'll have to check that out because I think the ceramic, I'm not sure if that's, well, if he has that, but make sure it's not just the interface.
Yeah.
That it's a ceramic interface, but the back of it is nickel like cobalt chrome anyway, so you're not gaining from that. If that's your sole reason for doing it.
No, I believe the back, the metal is titanium.
that's my understanding too.
So if that's the case, then that's not the prosthesis that he has the long experience with. That's a newer one.
I believe this one, he's been working with this one for 13 years.
The one that he's reported on is cobalt chrome. That's the one for 13 years. In the literature. But
well, the one that I was talking to him about, he said he'd been using for 13 years.
The Sonova Preserve.
Yeah, that's the one.
okay, well you'll have to find that out. The article published says cobalt chrome, but you'll ask him in the printed article not to. But that's what you want to do. That's why you would get information.
Yeah, because I absolutely do not want a hip replacement.
So, Dr. Mont, what kind of surgical approach do you use? Tell us about approaches. We have some people too.
I've used all the different approaches in my career, anterolateral, anterior, posterior approaches. I'm most comfortable with an anterolateral because it has great results. It doesn't take a long time for me to do that. I'm very used to it. I can do the other approaches at will, but that's the one I can make the smallest incision and have the easiest rehab, but I'm used to that. So the main thing I tell people is make sure you find a surgeon that is very, and you don't have to take them out of their comfort zone by doing one approach or another. There's been a bit of hype of different approaches having better results than others, but lately a lot of the literature and the reports are showing no real differences in approaches. Sometimes there's an approach that says you get out of bed a day earlier or something like that, but that's really not a major difference when you're looking at approaches. All the approaches that have looked at results by 6 weeks or 12 weeks down the line have not shown any differences. In addition, with a resurfacing, you're really limited to an anterolateral approach or a posterior approach. You don't really want to do that with some of the minimally invasive approaches. You had a posterior approach, correct?
Me?
Yes.
Yes, from Dr. DeSmith. Big long. He likes to open your way up, make sure you can see, get you all done. And you would think it would be bad and it'd be a long recovery, but it wasn't. I was out sightseeing 5 days later. He puts waterproof bandage on so you can swim or take a shower right away. I used one crutch for about 2 weeks and then none. You can't stop using your crutch if you're still limping. If you're limping, you still need an aid. Anyways, that's what I read and have been told.
Yeah, so, yeah, all the wounds, if you can keep them covered the first 10 or 12 days, you can get into the shower and get things wet as long as the wound itself is not getting wet. So there's a lot of materials like Opsite or these adhesives that can vacuum seal a wound area. So it's not like you have to not get wet for a prolonged period of time.
Dr. Mont, it's Grant. What do you think of the metal ion issue and now that with a surgeon that knows what he's doing like yourself and say the devices that are approved, BHR and maybe the Biomat, do you feel pretty comfortable that that's a not a huge issue?
I think that if you are used to doing resurfacing and you're putting them in at the appropriate angles, and you will minimize the chance of getting any metal ion issues. It's always something that we may be concerned about. A number of the people that have had a large experience with them, they're putting them in a standardized manner. If you put them in with a little bit of an opening angle, or they're tilted a certain way, they can get edge loading on the prosthesis. And then the person will be moving and they may impinge, or the metal may rub against the rim of the prosthesis, and that can cause excessive ions. And that is what led to a lot of the failures in the previous iterations. So I'm pretty confident, and there's a number of us in the country that are doing high volume. We're not getting metal ion issues. We don't know at 20 years or 25 years, but at this point they're doing very well if you put them in appropriately.
Right. And when Catherine, where we are from in Vancouver, there's really one surgeon who does them still. It's Dr. Clive Duncan. I just went and saw him on Friday. He's done a lot of them in his history, but not, he does probably maybe 20 a year now. How important is recency in terms of doing the operation from your perspective, from a surgical perspective?
If a person that is perhaps a Clive Duncan, I don't know how many hip replacements he's doing a year.
Like he would be one of our, I don't know if you know, but from in BC in Canada, he would be one of our top surgeons. Now he's, he's in, I think he's 70 now, but he would be. I know him very well. Okay. Well,
I don't know. What you're asking me is his volume right now. If you're saying forget about him necessarily, somebody doing 20 hip resurfacings a year.
But had a good history before.
Yeah, I'll try to answer that. Somebody doing 20 hip resurfacings a year is probably not enough if that's all you've ever done to really get good at it. It means you're doing one every 2 weeks, one every 3 weeks. It's a harder operation than a regular hip replacement. However, somebody that may have done thousands before and is continuing to do a lot of hip replacements every year, which is probably him. I don't know.
Yeah, I think so, yeah.
A well-spoken gentleman. He publishes a lot. I like him in terms of his scientific work and everything like that. So if he had done a lot of resurfacings at one point and had an experience with at least several hundred, got through at least 50 or 70 in a short period of time, and he felt comfortable, and then he was doing it at the pace you're describing, I would feel comfortable with that type of person if they're a good surgeon, because they're doing hip surgery all the time. He's the type that is doing primary hips. He's doing revisions. He's around the hip all the time. He's not going to lose his skills in that manner. If a person that had a massive experience and then they stopped operating for 1 or 2 years,
right.
And then they started doing 20 a year, I'm not sure about that, but I don't think he fits that bill.
Okay,
So
thank you.
You asked is a good one for other people. You have to learn to some point, but the beginning people on resurfacing typically learned with mentors. So if they did a fellowship, they were watching a mentor do 50 or 100.
Right.
And they were doing parts of the procedure, or they were getting used to it. So it wasn't like they just plunged in and they're doing 20 a year. And that would have been the best mode. The worst problems were the people that did a resurfacing once a month, as you said, and it's hard to get used to that.
Right. That's a great answer. Thank you.
If you have 5 hip surgeons in a practice, rather than have each of the hip surgeons doing what you just said, 20 a year, one every 2 or 3 weeks, most good orthopedic practices, they let one person do the resurfacings even when they were in the heyday. So that person, instead of the 20 by 5 surgeons, one person is doing 100 to 120 or 150 a year. They're doing 2 or 3 a week very regularly, and that makes sense.
Right. That makes a ton of sense. Okay.
And
I have a question. I have another question when you're done.
Sure.
From Toshiba, do you routinely collect follow-up metal ion data from all your patients?
No, I don't. We had done this at certain times, and I wasn't finding it very productive. We would test like 30 or 40 or 50 patients in a row, and we weren't getting elevations. So I typically do monitoring when patients have symptoms, and that's it for my group of patients. So if you had a resurfacing and you're starting to get groin pain or hip pain, things don't feel right, that might be a signal for metal ion levels. And we don't typically just use metal ion levels to make decisions. They may give us some hints. You may get a series of metal ion levels, but when we really want to assess for problems, we follow it up with, well, you certainly want to do the physical exam, learn the history, but then if you're concerned, then you would get metal ion levels, but you would supplement that with an MRI exam or an ultrasound exam. The MRI has to be done specially. It's typically called a MARS MRI exam. The MARS stands for Metal Artifact Reduction Sequence. So you can see any problems by the sequence getting rid of the metal, so then you can look at the tissue and if there's any adverse reactions.
So Toshiba asked another question. He said, I don't know if it's a he or she, what % have exhibited symptoms due to metal ions of your patients, I assume? I don't know, like big studies on all hip resurfacing.
I mean, there are different studies of different experiences. I don't think metal ions themselves, if they're slightly elevated, that's just an indicator that there could be a problem. There are a lot of people that have certain small elevations that may not have a problem. I think that when metal ion levels are way over, they have skyrocketed. They're way over 100 or even in the thousands, which are so rare. that could lead to symptoms. But typically metal ions on their own, if they're a little elevated, if they're below 100, they're not going to lead to symptoms, if that's what the question is asking about. There have been, in the literature, there have been about 12 to 15 cases where the metal ions have been very, very highly elevated, way in the hundreds, and that can be implicated with toxicity. But those are very, very rare cases.
Was it almost all women, those cases?
I don't right now. It probably is the majority of women, but I can't give you the exact breakdown. I can, if you email me, I can get you the article. There's an article that with about 12 offers on cobalt toxicity, and I don't remember the male-female breakdown.
Do you think?
But some of them were not only metal on metal prostheses. There was ceramic on poly also. There were a few others, but I don't have the male-female breakdown offhand.
I wanted to say, if anybody else, since there's not 100 of us here, wants to ask a question, come on and do that. Toshiba is really interested in the metal ions. He or she asks, it seems that the metal ion issue is the only nagging knock on the BHR. It would seem logical for a large-scale tracking study to debunk the stigma. How about that?
So what do you mean by a large, there have been some studies that have shown, that have followed patients out, and they're variable results. Some of the surgeons get very low metal ion levels when they have, there are a number of surgeons that have used this, so when they've checked metal ion levels, they haven't been terribly elevated except on some rare cases. The ones that get elevated, Catherine asked, no, who was it, Catherine Nan asked, more often in women than men that do have some elevations. They view that as maybe a more immunogenic response in some women. So there are some people that are not having, with some devices and the techniques, not having terrible elevations at all, or they're not having a problem with metal ion elevations, even starting into the second decade. There are other studies that do have some problems with certain devices, certain techniques. So some of it is device related. Some of these were taken off the market. And some of them are technique related. And some of them may be patient related. So it is true that probably a patient that has allergies to metal, which might not be the best candidate for a metal on metal resurfacing.
Dr. Mont, it's Grant. Just like 10 years down the line, what do you think hip resurfacing will look like in terms of the bearing surfaces? And do you think it will become more in vogue, more like it was back in 2008 when it was, I think when we're like 20% or 15% of the operations versus 1% now?
So I would like to think that there's going to be another resurgence in resurfacing. I certainly spent a good part of my surgical career, over 10 years, focusing on resurfacing. The metal ions were an issue for the field. These were originally felt that you could use these large femoral heads, and the technique wasn't as dependent as with smaller femoral heads. It turns out, as I said earlier in this conversation, these have to be put in with the very meticulous technique to avoid edge loading. So I would, in answer to the question, I would like to think that there are many of the companies are working on new devices. They are working on interface surround